Okay, so let's get started then. So let me introduce Olga to those who
Myocardial Bridge.
don't
There you
know
go.
Olga. So Dr. Olga Toleva graduated in medicine in Sofia, Bulgaria, and completed her family medicine and internal medicine residency at University of BC, Vancouver, and then completed her training in adult cardiology and interventional cardiology at the University of Alberta, Edmonton. She has also a master's in public health at the Harvard School of Public Health. She is an interventional cardiologist and an expert in coronary physiology, microvascular dysfunction, and vasomotor coronary disorders, which has been getting a lot of attention more recently. Now, she's worked as an assistant professor at the University of Manitoba from 2014 until March 2021, and then moved to the US to our loss, and has been an associate professor of medicine at Emory University for the past 3 years. She is now appointed the lead in advanced coronary physiology and microvascular dysfunction at Georgia Heart Institute in Northeast Georgia Medical Center. She's deeply involved in invasive coronary function testing in the cardiac cath lab and has a strong interest in women's heart health, especially in spontaneous coronary artery dissection, myocardial infarction without coronary artery disease, which is MANOCA, and ANOCA, as well as microvascular dysfunction. Now, I asked her specifically to speak to us about Myocardial Bridge, which is her area of interest. Because there's been a lot of controversies recently, and a lot of us are familiar with the presence of it, but when and how it causes problems and when should it be managed is one that I was hoping Olga would be able to tell us a little bit more today. All right, over to you then, Olga.
Thank you very much for the introduction. I hope the slides move, and that's where I am. Perfect. All right. So without further ado, myocardial bridge, we are born with it, but why it would be a problem? These are my disclosures. I am consultant for Abbott Vascular and Philips Volcano, and there is no conflict for this particular presentation. Myocardial bridges are a part of the myocardium that could be a very small myocardial fibers or a big, extensive, long segments that usually go on top of the epicardial vessels. In most instances, they're seen in the left anterior descending arteries, but there are cases, which I'll show you examples, where we see them in the circumflex and the ramus, and more rarely in the right coronary artery. We call them a bridge because the artery goes under a bridge, as it's shown on this cartoon here. Myocardial bridges, are they common or uncommon? This has been always a big question. And what we know and what we've learned from different series is that about 5% of all angiograms that we do, when carefully studied, show myocardial bridge. And that could be as high as 16% if we really pay close attention. On an angiogram, they look like a systolic compression, or what we call milking of the artery. Up to a third of the patients with typical angina and normal coronary arteries may have these myocardial bridges, but that does not necessarily mean that they are causing any symptoms or particular problems. When we look at coronary CTAs, the actual frequency of seeing them is much higher, between 15 to 25%. And in fact, a lot of the CTA readers may even not report them because they're worried that if it's reported as an anomaly or abnormality, patients may get unnecessary testing. And when we look at autopsy, there's about 55 to 80%, which is quite high. And I am not sure if these were pre-selected series, but that's what we have found in the literature. We know that they're a congenital abnormality, and as I mentioned, they're more commonly seen in the LAD. We also see them frequently in patients with hypertrophic cardiomyopathy. So pay attention when you have a patient like this, when they undergo either CTA or coronary angiogram. Keep your eyes on specifically the LAD. What is the pathophysiology? How do myocardial bridges cause ischemia? Well, first of all, the big paradox is that we know that the coronary arteries fill in diastole. and the bridge usually causes compression during systole. So why does it then cause ischemia? Well, because during that compression time, there is still some myocardial disruption of the myocardial perfusion, and there is disruption of the diastolic relaxation. And the faster the heartbeat is, the shorter the diastole is, so there is less time for filling up the vessels. What else happens is the fact that because of these mechanical interferences in this area of the vessel, there is increased shear stress, which could lead to endothelial dysfunction and vasospasm. And I will show you some series from Stanford and from my own institution where the prevalence of endothelial dysfunction and vasospasm in patients with myocardial bridging could reach up to 80%. So they're very commonly related and present at the same time. Due to the shear stress, the proximal part of the myocardial bridges are prone to atherosclerosis. And it is very interesting that when we look at these vessels under IVUS or OCT, it's the distal part of the vessel, distal to the entry point of the bridge, is spared of atherosclerosis. And there are theories that this is associated with just the embryonic development of this part of the vessel, which is very interesting. So what is the clinical presentation? As we already mentioned, majority of them are asymptomatic. So when we see them, we often don't really get too worried about it. But again, over time, some of the patients may develop symptoms. So it's good to be aware if a patient at some point has had this noted on angiogram. Some patients may present with typical anginal symptoms, which could be exertional and also exertional dyspnea, as well as effort intolerance. A lot of these patients have some atypical symptoms like palpitations or arrhythmias and some atypical chest pains, but there are some serious presentations like sudden death, which is rare, and it could be seen in young athletes. So it should be one of the differential diagnoses, and I'll show you a couple of cases of that, as well as patients usually do not present in a young age. However, we've seen young athletes present with this as well. It is very common that patients with bridge may have some presyncopal symptoms. And it's very interesting that, especially effort that causes tachycardia would trigger these presyncopal symptoms. And the belief is the shortened diastole and transient ischemia that significant bridges cause. So why do bridges present with symptoms in adulthood if you were born with it? There are several factors that may influence the clinical significance and symptoms expression. First of all, the pure anatomy of the bridge. The longer the bridge is and the thicker the layer of muscle on top of the artery is, as the higher incidence of this causing mechanical shear stress disruption, as well as future issues with hemodynamic significance. In a lot of the patients, there are visible kinks. So there are several segments of the bridge and layers of the artery in between that is bulging and going on the surface. And in these areas, because of the kinking, there could be potentially issues with shear stress again and early atherosclerosis. The dynamic contraction of the muscle makes these bridges very difficult to diagnose for the pure problem that our usual imaging techniques like coronary CCTA, the patients are in resting position. So the loading of the ventricle or the increased contractility is missing. But in some situations, we could see that dynamic change if we do butamine provocation, which remains to be the gold standard of us evaluating bridges. Left ventricular hypertrophy, as I already mentioned, plays a significant role as this increases the thickness of the myocardial bridge, which causes more severe compression over the epicardial course of the vessel. shortened diastole with tachycardia and exercise, and something called perfusion gradient. So in some patients who have high left ventricular end diastolic pressure, during diastole, there is no significant gradient to allow for the filling of the coronaries and could present with ischemia. And as I already mentioned, there is a very strong association between coronary vasospasm, endothelial dysfunction, and myocardial bridges. So there's two entities that happen at the same time. Mechanical compression from the bridge with all these hemodynamic changes that I explained earlier, plus superimposed spasm that could cause these patients to have angina not only during activity, but also at rest and sometimes in the middle of the night. The proximal atherosclerosis is believed to be caused by the altered proximal endothelial cell function with the decreased nitric oxide release and shear stress that causes an early development of atherosclerotic plaque at the entry points of the bridge. And finally, the coronary flow is regulated in diastole by endothelium-regulated mechanisms, which is endothelial mediated vasodilatation. And if there is endothelial dysfunction, this is technically impaired. So how do we make the diagnosis? We have to establish that the bridge is causing ischemia. And as I mentioned, a lot of the tests that are not involved in actual physical activity or stress may miss the diagnosis of myocardial bridging or the ischemia caused by it. Therefore, the stress echo with activity or with dobutamine has remained one of the gold standards if we're looking at diagnosing them non-invasively. Other features that we could see during the echo contraction is a focal mid-septal buckling with apical sparing, and it's in the area where the ischemia is occurring as it correlates to the segment and the LAD, as this is the most common vessel involved in myocardial bridging. The cardiac catheterization with functional provocation is the real true invasive gold standard. But even there are challenges as far as what are the criteria and the cutoffs, and we're going to talk about it a bit later. But what is important is when these patients come into the cardiac catheterization lab, that dobutamine provocation is performed because we really have to increase the inotropy of the heart in order to provoke the bridge and the contraction and see its true hemodynamic effect on the perfusion and circulation of the heart. There is often an overlap between different conditions, like, as I explained, coronary artery disease, vasospasm, and endothelial dysfunction. And there are different testing protocols that are used in the cath lab to provoke them. The coronary CTA is a very essential part of the diagnosis of bridges, especially for the fact that it could measure very well the length of the bridge as well as the thickness of the overlying myocardium, and could be used as a map for surgeons if they decide to proceed with unroofing of the bridge, as this is one of the treatments of the condition if it causes severe hemodynamic compromise and angina. So we're going to talk a little bit about functional cardiac catheterization, which is the invasive gold standard for evaluation of these patients. And in preparation for this, I know at Ottawa Heart you have vast experience with functional cardiac catheterization utilizing the CoroFlow system. In general, when patients come into the cath lab for this test, they have to be prepared in order for us to get the best effect and the highest yield of diagnosis. So ideally, we discontinue all negative chronotropic agents and vasodilators for about 24 to 48 hours before testing. So they should be off beta blockers, off calcium channel blockers, and off nitrates. And this is the standard protocol for testing for microvascular dysfunction and spasm as well. In addition, they should be off caffeine because we also test non-endothelial pathway with adenosine. And what we do is we measure resting flows with vasodilation. We do testing for endothelial dysfunction and vasospasm. And finally, flow and contractility with dobutamine. This paper was a white paper that we published about 2 years ago now from the Microvascular Network. There were some participants from Canada, Dr. Stephen Miner. We decided to all gather information about coronary function testing and make it easy for the practitioners of how to interpret and make the different diagnosis of motion and the patients who have non-obstructive coronary artery disease but angina or ischemic symptoms come into the hospital. So in essence, coronary function testing involves coronary physiology. It is performed in the cardiac catheterization lab for patients who have unobstructed arteries and unexplained causes for angina or ischemia or on stress testing. The test encompasses several domains that we use, and the usual testing is in the LED territory. What we do is we do a diagnostic coronary angiogram, and then we cannulate the left anterior descending artery with a flow wire and perform measurements to assess for microvascular dysfunction, which is the first tab here. That is resting flow, and then subsequently a provocation with adenosine, so hyperemic flow to assess microvascular dysfunction and endothelial independent pathway. And we check for specific cutoffs, which is coronary flow reserve of less than 2 to 2.5 and index of microcirculatory resistance of greater than 25. The second step of the test is testing of the endothelial pathway, which is performed with acetylcholine, which normally is a vasodilator, but in patients with abnormalities actually causes paradoxical vasoconstriction. If following the protocol, there's 3 different doses we give, but at the spasm dose, which is 100 micrograms of acetylcholine, if the patient shows severe vasospasm on their angiogram, we consider this Prince-Meadows angina or vasospastic angina. If the narrowing is between 0 to 90%, so not very severe, then we call this endothelial dysfunction. And if we don't see narrowing, but the patient experiences the typical anginal symptoms they complain about, and we see ischemic changes on the EKG, we make the diagnosis of microvascular spasm. All 3 of these entities are considered endothelial pathway abnormalities. The final step of the test is performing an IBUS that often gives us an idea of subclinical atherosclerosis, and in some cases is the way we identify myocardial bridges. And if we do identify a bridge, then we go on to the last step of the testing, which is dobutamine testing for myocardial bridging, which involves pressure wire measurements with dobutamine. And what we aim for is a target heart rate of 80% of the age predicted. And the measurement we go for is the RFR on the coral flow system, lesser or equal than 0.76, which is being validated now to be a good cutoff for hemodynamically significant myocardial bridge. So this is obviously quite extensive evaluation of the coronary circulation, but I will show you some cases now and walk you through of how we do this in practice. This protocol is the Canadian protocol, pretty much same thing. The only thing that I wanted to add here are the different dosages of dobutamine. They are the same dosages as what we would do in dobutamine stress echo if we are performing dobutamine stress echo. So we start with 10 micrograms and we go on with increase by 10 micrograms every 2 minutes up to a maximum of 40 micrograms. And
Olga,
if the patient, yeah.
Your screen, you stopped sharing for some reason.
Oh, how about now? something popped on the screen. I think maybe my time expired or something. Hang on, let me just go back to where I was earlier. Because something popped from the Teams and it...
Is Faye still on the line? Faye, can
I
you help?
wonder if it kicked me out. Yeah, I think it kicked me out. It just, the share button disappeared. So maybe if you could just make me a
Presenter.
presenter
Faye?
again.
Yeah, just to promote you to be the presenter again.
Thank you so much. I guess probably because it's a longer presentation. All right, can you see my screen now? Let's see. It should work now.
Yep. Seeing your screen now.
How about now?
Yep.
You see my slides?
We do. I do.
Perfect. All right. Excellent. So what I was saying is that the dobutamine, the maximum dose we give is 40 micrograms. And if we don't reach the target heart rate, then we add atropine 1 milligram to achieve the heart rate in order to measure the significance of the bridge. So I'm going to show you some cases. This was the actual very first case that inspired me to be very interested in bridges. This was about almost 3 years ago now. This was a young athlete. He was 19 years old. He was a college basketball player. I always show this case because it was very dramatic presentation. He collapsed on the court and was resuscitated by his teammates successfully, and then underwent extensive evaluation in Florida, including normal cardiac MRI, normal EF. They checked for QT prolongation, and eventually a coronary CCTA showed the myocardial bridge in the LAD. So I got a call from the cardiologist that deals with top athletes at Emory, where I was working at the time, and said, well, I have this young guy and there is a bridge and we don't know what to do. And is it really the reason why he collapsed? He already had an AICD implanted at the time. So I consulted with some of my colleagues. Stanford group is probably the one with the most experience in myocardial bridges, and they encouraged me that they've done this in young athletes and it could be a cause for sudden death in athletes. So with that equipment, I went in to perform his coronary angiogram, and you could see the AICD lead here, as well as a significant systolic constriction into this ramus artery, as well as on the next slide, I'll show you what happened after I gave nitroglycerin. The LAD had quite pronounced significant systolic constriction, so he had 2 myocardial bridges, one in the LAD and one in the ramus circumflex artery. After that, I proceeded with, so I used this paper as a guide of how to interrogate myocardial bridges. For those of you that are in lab, I really recommend, this is by the Stanford group, and Dr. Jennifer Trammell has probably the biggest experience. So what we look for is when we do an IBUS, and this is the hallmark, because often bridges that are hemodynamically significant, they may not be very visible on angiogram. Like this one was pretty obvious, and only IBUS could actually demonstrate it. And you could see here that the hallmarks on IBUS are this black ribbon here, which is the actual overlying myocardium, and it is the actual myocardial bridge. And if we see compression of the vessel, and I'll show you how it looks like, more than 10%, it's considered to be present as a bridge, but then this is something that is very impressive when we see it. So I'll show you what it looked like in this particular athlete. This is his bridge here. You could see on the bottom the black ribbon, and then the visible constriction of the LAD during systole as I perform the IBUS. So in this paper, they suggested an actual morphological equivalent for the hemodynamically significant myocardial bridges, something called Myocardial Bridge Muscle Index, and it could be obtained by measuring the length of the bridge on IBUS together with the halo thickness. They correlated this with diastolic FFR, which used to be the only validated standard for measurement of severe bridges. And it showed that if this myocardial muscle index is more than 12.2, it's strongly correlated with hemodynamic significant bridge. So in this particular athlete, by morphology, this was severe. Obviously, it was very clear on the angiogram as well in the two vessels. Now, the next step that is very important if patient would be considered to undergo unroofing is the actual mapping for the surgeon of the length of the bridge and its location on an angiogram, because it will guide the surgeon to from where to actually take off the muscle layer and free the artery from underneath the bridge. So the way we do that is we use the angiogram and the longitudinal view on the IBUS, and the mapping goes based on side branches. So these are the septal branches that are correlating to the IBUS, and these are the diagonal branches. And that way, the surgeon, when they are in the operating room, they look at this particular view of the angiogram, and I'll show you how they actually do the unroofing. So that's a very important and essential part of the collaboration between us and the cardiac surgeons who do the procedure. These are the different indices in physiology that have been published. The original work was done on provocation with dobutamine and diastolic FFR. And that has been validated as the gold standard for patients with myocardial bridges. Some people ask as to whether adenosine FFR could be sufficient, which is our standard protocol for any stress test. However, in myocardial bridges, it could miss a lot of positive myocardial bridges, so it's not a good method to do. It has to be dobutamine. So in this particular young man, I did myocardial microvascular testing, and as you could see here, he had severe reduction in the coronary flow reserve, and also the microcirculation index was elevated. So he had true microvascular dysfunction by adenosine non-endothelial pathway. And then I did the adenosine FFR, and he already became ischemic just with adenosine, and I reproduced his symptoms. So in his case, with all the data I had, including the IBUS, the systolic milking, the index that I measured, and positive adenosine FFR, I did not pursue dobutamine because it made me very nervous, especially his presentation of sudden death. I didn't want to induce some ventricular tachycardia and cause issues. So again, the pioneer work on provocation of myocardial bridges was done by Dr. Javier Escaned from Madrid, who is a very good friend of our community in Canada and US. And what he validated was that if we do an FFR with adenosine, like I said, it's not very sensitive, so we have to perform dobutamine FFR. And because the problem ischemia is expected to happen in diastole when the heart is not constricting, and if we show that in diastole there is ischemic FFR during dobutamine provocation, that means that that bridge does not allow sufficient filling of the artery between two systoles. So this is kind of the logic behind why we measure diastolic FFR. The technicality behind it, though, is very difficult because it has to be done manually. There is no an automated system that could actually measure that diastolic change between the proximal and the distal part of the sensor when we do the dobutamine testing. And that's why we now had tried to validate other indices, which are the resting indices like IFR and RFR, as a better and equal to the diastolic FFR with dobutamine. So what happened to this young man is after the diagnosis of the bridge, we tried extensive treatment with nebivolol, which is a beta blocker that helps with vasospasm because he also had concomitant vasospasm, diltiazem, and despite that, he did not get better. So eventually I referred him to the Stanford group where they had a lot of experience with athletes and their rehabilitation after surgery, and he underwent sternotomy with open unroofing of both LAD and ramus circumflex. At the time, I explored robotic options, but because of the extensive several vessels involved, it was felt that sternotomy was the better option. And this is him 3 months after his surgery, back on the court, playing basketball and back to competitive sports. So he did really well. This is how I started thinking that bridges are not an innocent thing. So I paid more attention to it. So to summarize the findings again, dobutamine diastolic FFR of less or equal than 0.76, the halo thickness, the length of the bridge, the longer it is, the higher likelihood of hemodynamic compromise, and then that myocardial muscle index as a helpful tool to have when you do IVUS. And for whatever reason, you cannot do dobutamine. And then the deeper the bridge, the higher a possibility for hemodynamic compromise. So the Stanford group went on further, as I mentioned, to validate the more accessible indices like IFR, which we all have in the cath lab, or RFR, which is associated with the CoroFlow system. And they identified that diastolic FFR of less than 0.76 correlates well with dobutamine IFR, but even better correlation with dobutamine RFR. So from that work, we all now are using RFR, which is the CoroFlow resting index, for when we measure dobutamine provocation of bridges. I want to show you more cases because I know this conference is fueled by, interesting cases. So this particular patient here is a 41-year-old female patient, mother of 3, who presented with chest pains to another institution. And at the time, heart catheterization showed myocardial bridge. You could see it's actually much more subtle than the athlete's bridge here in the mid to proximal segment after that big diagonal branch. She continued to have chest pain despite therapy with beta blockers and calcium channel blockers. She went on to have dobutamine stress cycle to evaluate.
Wait, what? No, they're just really annoying.
The severity of the bridge, and it showed the ischemia in the anterior wall. So this is a good alternative, non-invasive way to make the diagnosis. However, she was referred to me for second opinion, and I discussed with her that we should pursue a full functional study because of the association bridges with coronary spasm as well as microvascular disease. So I performed the study, and as you could see here again, severe microvascular dysfunction with very low CFR of 1.2 and IMR of 51 with adenosine. During the adenosine infusion, her FFR across the bridge was not severe. So that's an example of how severe bridge may not always give you a hemodynamic problem with adenosine. But what was interesting here is that she had severe diffuse distal coronary vasospasm. You could see the artery completely constricted, suggested that she has 2 other underlying causes for chest pain outside of the bridge. Finally, we went on to perform dobutamine provocation, and this is the picture with dobutamine. So you could see the bridge more exaggerated here in this mid segment. And on the ends here, you could see in the second here some of the black ribbon, which is the winking sign of the bridge. So you could see small amounts here on both sides, and you could see some mild constriction. systolic compression. You could see it more here. And this interesting thing with this bridge is that it actually was almost enveloping the artery like a band. So there is some here, and then more proximally almost looks like a ring around the artery. So bridges could have different morphologies, from just a little band on top to like a real circular bands that are much harder to unroof. So we tried different, so this is with the dobutamine. Her RFR dobutamine was 0.76. It is important when you do this in the cardiac catheterization lab to prepare to reverse it, because the patient is extremely uncomfortable. So one important thing is to give them ondansetron before you embark on the dobutamine, and then reverse immediately with IV metoprolol 2.5 to 5 milligrams. As they become extremely unwell with the provocation. It's really not a fun thing to do, but it really helps us understand the hemodynamics. And of course, the butamine, like I said, you could see it more exaggerated. The other way we could see them well exaggerated is after giving nitroglycerin. So with this lady, we tried aggressive medications, but she was unable to tolerate anything. Like whatever we gave her, it made her very hypotensive. We tried beta blocker and calcium channel blocker compounds. We tried different medications, but she also had a concomitant POTS syndrome. So, really low blood pressures and syncopal symptoms. Eventually, I gave her ivabradine, which is an alternative option for heart rate control in these patients, and L-arginine for her microvascular dysfunction. But again, she was not able to even do daily activities to take care of her kids, pack their lunches, or take them to school. So we discussed myocardial robotic unroofing, which is, I'm lucky to have a surgeon in my institution who is world-renowned robotic surgeon. So he was very comfortable doing that. This was the first we did robotically here. So that was in October of 2024. And you could see here the actual bridge unroofing and how deep it was. So that was the area of where there was a circular type of band around the artery, which he freed on both sides. And after that, we are now about a year later. She is angina-free with rest and activity. Still has some significant symptoms from the POTS syndrome, but we control this with hydration, elastic compression stockings, and ivabradine. And she is able to hike and ride a bicycle and take care of her kids, and is very happy. So another patient here, this happened just about 2 months ago. This young man, it was just like a repetition of the other basketball player, another 19-year-old, and his symptoms started after a strep throat. He started having chest pains at maximum exertion. I was about 6 months ago when he was unable to do the conditioning practices with his team, and they basically benched him. And every time he tried to do any moderate, not even aerobic activity, he was presyncopal. So they did all kinds of tests for him. They did a tilt table test. They thought maybe he has POTS, but again, cardiac MRI, which was normal, echo, that was normal. They saw some small pericardial effusion. They did an ANA screen, which was of unknown significance. So it was 6 months of real torture for him, because this was his first year in college playing basketball, and he was devastated. So I called my friend, the exercise sports cardiologist, and I said, I have another basketball player. He hasn't dropped on the court, but he's been presyncopal on numerous occasions. Can you please see him and tell me what you think? And then his CCTA, which was read as normal, I went back and re-looked at it, and with 2 other colleagues, and they said, well, there looks like there is a bridge there. So on his VO2 cardiopulmonary exercise test, he showed clear ischemia with 2 millimeters of downsloping ST depression at peak exercise and chest pain. And at that point, we had a long discussion, and we said, okay, we're going to have to do a functional study. And here is this young man, a bit different looking, not as pronounced as the previous athlete, but you could see here a long segment of the LAD with systolic compression. It starts from just underneath that diagonal branch. It goes all the way down into the distal LAD. And it's very pronounced here in this proximal segment. So keep your eye on this because I'm going to show you the evolution of it as it goes with when we give nitroglycerin and dobutamine. So this is his adenosine provocation. And finally, acetylcholine, there was no major spasm. So, and in his case, there was no endothelial dysfunction. After giving nitroglycerin, you could see the exaggeration of the bridge, and that's something very common with bridges. Vasodilatation causes exaggeration of their systolic compression. This is another type of IVUS that could be used. This is the solid state IVUS, Eagle Eye by Volcano, and you could do a co-registration with the angiogram at the same time. And you could see here the bridge with some, in a second here, I'll point to it. So some of that. So this one is not as thick as the previous one, but it's right here in the spot on top between 10 and 12 o'clock. And there is some systolic compression that is visible here. You can see it clearly, like someone is grabbing and squeezing. And the length that I measured was about 57 millimeters. So this young man, we had a long discussion. This is his dobutamine RFR. It was very ischemic, 0.64. It was not even at peak heart rate for his age because he started having the symptoms much earlier and didn't want to make him very ischemic. So that's another debate, whether you really need to reach target or if you see ischemic RFR, you stop because they become extremely uncomfortable and unwell with this provocation. So after long discussion with his family and him, we tried different medications, metoprolol, ivabradine, nothing works for him. He underwent robotic unroofing just yesterday, and I'll show you his picture. So another interesting thing about dobutamine RFR is what we call the fingertip pattern. It's this spiking here, and this is when the muscle bridge actually constricts on top of the FFR wire. Very clear systolic compression here during dobutamine. And this is him yesterday. So these are fresh from the oven. Yesterday I took the video in the OR to show you how actually is done with the robot. This is the proximal part of the bridge where we saw the clear compression just underneath the diagonal branch, which is at the bottom at 6 o'clock. These are two little clips that were given for that vein that was overlying. It was clipped, and this is the final picture of the bridge, about 55 centimeters, so very close to what we measured. As you could see here in the distal part, there was a bit more extensive unroofing, and he is seated in the chair today looking good. I'll do one more case because I think it's good to kind of see variety, but this patient here is a 55-year-old African American with history of high blood pressure. She had chest pain and syncope and actually presented with a non-STEMI. So it's interesting that, the presentations could be from sudden death to, exercise intolerance and stable angina, but some of these patients may present with acute myocardial infarction without obstruction. So she is from Washington, D.C. She went there to a local hospital. She had a high elevated troponin and a cardiac MRI showing anteroseptal MI with edema consistent with evolving MI. Her echocardiogram was read as normal EF and akinetic segment into mid to distal anterior wall. At the time, she underwent left heart catheterization, and they weren't sure what exactly is the abnormality in the LAD. Some people thought there was a mild disease. There was no IVUS performed, so she was started on the typical therapy for Minoca patients with nitrate, metoprolol, ARB, and aspirin. However, her symptoms persisted and they were quite severe with emotional stress and physical activity to a point that she was completely debilitated. She would have about 5 to 6 episodes per day and she couldn't carry any regular activity. And then she had repeated heart cath with IVUS and dobutamine, which showed a myocardial bridge, but they didn't do the acetylcholine and the adenosine. So she came for a second opinion and came from out of state. So she looked so unwell. I actually admitted her to the hospital because I was worried that she had unstable angina. And by looking at the angiograms, I wasn't sure exactly if this was actually coronary artery disease or what exactly was that abnormality here in the proximal and mid segment. As you could see, it could be coronary artery disease. So this is her angiogram at baseline that I performed. And subsequently, we went on to do a full functional study. So this is a type of bridge that doesn't show a lot of systolic compression, but you could see that link here. This is the area that goes on top. And from here to here, the vessel is underneath the bridge. I mean, for those of us that spend a lot of time in the cath lab, you could easily think that this is coronary artery disease if we had not done the IBUS and the vasodilator. So I'll show you what happened to her. So this is her adenosine. You could see the vessel starts to open up a bit more. And then with acetylcholine, her artery completely shut down. So she had critical spasms, basically with ST elevation. And then after we gave the nitroglycerin, this artery looked so much bigger. So in her case, the spasm was predominantly confined into the bridging segments, and it looks like even at baseline, at rest, she had some spasm that made the artery look like she has atherosclerosis. And I will show you afterwards how we measure the bridge. So then I used an IVUS, and we basically could do that empiric way of when we see it on the IVUS, we step on the CINI to measure the distal part, and then we step on the CINI. This is where that area was that was going on surface, and then again where the proximal part of the stem of the bridge is. So in her case, she had the dobutamine RFR that was very ischemic with 0.68 with target heart rate. And she also had the severe coronary vasospasm, but normal elevated microvascular resistance. So the measurements, how we do the measurements is also very important. We do a systolic and maximal compression at systole and diastole and measurement of the bridge here. So IVUS is of extreme importance of the identification of the bridge. And as you could see here on these IVUS images, she had absolutely no atherosclerosis. It's playing a little slow, but take my word for it. All of these segments that looked like she had disease were just completely normal. Here is her dobutamine, which was very positive, and this is her unroofing, which was done at the end of January, and she's doing well since we're at about 1.5 months now, and she is recovering really well and has no further angina. So this is the cohort I've done. I've done about 250 coronary function testing in the last 2 years since I've been in this new center. And the mean age of these patients is about 58, so they're relatively young. We're talking about all patients with, angina with non-obstructive coronary arteries. And it's interesting to see that it's not predominantly female disease, but it's 56% male sex. When I have actually done their provocation, I've had patients that had 11 patients that have undergone robotic assisted enrolling when my partner here, Dr. Guy. So this young man yesterday was number 12. And what you could see here that 35% of them would have abnormal coronary function testing as it relates to microvascular dysfunction. And when we test for spasm, myocardial bridge patients, 82% of them would have spasm with acetylcholine. So when we test them, they really need to undergo the full comprehensive evaluation, because I've seen cases where they've undergone unroofing and despite that continue to have symptoms because they have concomitant spasm or microvascular disease. And finally, the treatment of this condition, of course, is very challenging to make the diagnosis, but once we reach the treatment, the goal is to treat all atherosclerotic risk factors, because there is a risk of premature atherosclerosis and the areas of increased shear stress. Beta blockers are the first line of therapy, and then calcium channel blockers, especially if there is concomitant spasm. There is conflicting data about nitrates, but we know that nitrates may make the compression worse, and I showed you that on angiogram, so they should be used cautiously. But if the patient has concomitant spasm, they definitely are a medication for relief of symptoms. There have been case reports for these bridges being stented. However, if it is done, it has to be done from end to end, so the whole entire bridge segment with one single stent, and under IDA's guidance, because if we just do it on angio, there have been reports of stent thrombosis due to stent fracture or perforations, because the sizing is very challenging. You saw that there is a huge variation between systole and diastole in these arterial segments. And finally, in roofing, it has to be done in the hands of experienced cardiac surgeon that has many cases under the belt, because of the way we map them, the way we outline them for them. They need to be comfortable, taking care of this. And then the more modern, I showed you about 12 cases now. All of our cases have done really well with robotic. Bypass grafting doesn't really work well. Excuse me. I've had a couple of patients that had severe atherosclerosis inside the bridge and the proximal segment, and they underwent bypass grafting, and it not always works well because, first of all, there could be difficulty in anastomosing in the area of bridge because it's under a muscle. And sometimes there could be a lot of competitive flow from the native artery because it's a dynamic constriction, and the lemma may go down. And finally, in conclusion, myocardial bridges are relatively common and they are typically benign, but are a potential cause of angina among patients with ANOCA. Functional cardiac catheterization can identify physiologically significant bridges. And always remember that doing the comprehensive testing is important because the bridges are associated with endothelial dysfunction, vasospasm, sometimes atherosclerosis or microvascular dysfunction, and successful treatment may involve multiple modalities. And I'll open for discussion.
Thanks very much, Olga. I'm just watching the chat boxes to see whether there are any questions, but I'm sure there will be from my colleagues who may be non-invasive cardiologists. But perhaps I could start. In the lab we do lots of these procedures, but we have not routinely done the debutamin for myocardial bridging. I've couple of concerns. Perhaps you could help allay my fears. One, wire in the artery with dobutamine, with the contractility increase and such. Two, how long has your average case taken if you were to do the complete assessment, including dobutamine? And lastly, we have a different version of IVUS. How useful is it for you to have? If you had a choice, would you insist on the one that allows you to correct the volcano system? Is it, do you find a huge difference between that and the usual IVUS?
Yeah. To answer your first question about the
Duration.
danger and
Yeah.
duration. So here is the duration. So mean duration of functional study is about 74 minutes when we add the dobutamine. This is with the three. So I've done 54 dobutamine provocations, which includes adenosine, acetylcholine, and dobutamine. So if I don't do dobutamine, my average case length is about 60 minutes. So it adds approximately 15 minutes to the case. So total of 74 minutes, because you have to do all the stages and you have to wait for them to build up to target heart rate. So as far as safety, yeah, some of them look very volatile. I usually utilize a JL35 or a JL4 guides, which are relatively safe and more aligned with the left main. And of course, I constantly watch, for any dampening, and we haven't had any issues with that. And Dr. Trammell, who published her series, did not report any guide dissections in any of her cases. So so far, the safety of this they're not big studies because condition we don't do that provocation as often as we do PCI or diagnostic cath, but it is safe. So finally, about the co-registration. So ideally, the best IVUS to use, I just gave you examples of 2 different IVUSs, and I'm going back here to my slides, but ideally, the Boston IVUS with the longitudinal view is the best IVUS for this. So if you don't have it though, this is an option. My personal preference and what Jennifer Trammell has suggested too is to use the Boston IVUS with the longitudinal view. And the way you map it is you would take an angiogram view, and then you will see where I'm just trying to find the paper from Stanford I showed you earlier, where you could see all the septals, and this is basically the mapping. So you would use the Boston IVUS, the longitudinal view, and then you will map out all the septal branches, septal 1, septal 2, septal 3, and 4, and you can use it in the usually the LAO cranial view to draw them, and on the IVUS you could measure the length. The only downside of this automatic pullback is that if you really want to see systolic and diastolic compression, you have to do a second run and do it manually and stop in the area of maximum compression and take a pause and see it in systole and diastole without constantly pulling back. It's just a technicality, but most people prefer Boston IVUS over that other one that I showed you. But I just wanted to, present that there's different ways of doing it with different IVUSs. With OCT is very challenging because the pullback is very fast, and the appearance of the bridge is not the same as what I've showed you with the IVUS, the half moon sign and the halo. That is very clearly seen on IVUS. The downside of the IVUS is that you don't see the structure of the vessel as well, like if you want to look for atherosclerosis or erosion and whatnot.
I mean, that was what I thought as well. I often wonder how many of these patients have been told that they have no coronary artery disease and then sent away with no diagnosis at all. Kevin has a question for you. Kevin, go ahead.
Great, thanks so much. Can you hear me?
Yeah.
Oh, wonderful. Thanks so much for that excellent presentation. It was super informative and really great, interesting cases. So thank you for that. I had a question out of curiosity. coming as a kind of imaging cardiologist, do you have what's your opinion on workup for the physiologic significance of these bridges with respect to dobutamine as a stressor agent versus exercise as a stressor agent in the non-invasive workup for these patients?
Yeah, it's a good question. I think that and I showed you examples of both. Like in the young athlete, the last athlete that I showed you, he showed ischemia with just cardiopulmonary exercise test. But if we really want to be certain, I think the butamine echo is a very good non-invasive substitute, and I'll tell you why I like it, because for a while I was doing coronary function testing, and even though I had the butamine protocol, the cath lab didn't have the nurses were not comfortable running it, so I had no choice. I could not do the butamine in the cath lab. And when I saw a bridge in some of these patients, I brought them back and did the butamine stress as a documentation whether this bridge would be causing any issues or not. So it's a good way to, if you want to go back and check, to use the butamine stress, because you really need to push the inotropic effect to a point where you could see target heart rate and ischemia. But again, with the butamine echo, they become very uncomfortable too, and you have to wait for a while to see the effect. So these are uncomfortable tests, let's put it that way. Yeah.
Are you volunteering, Kevin? He's sending you the referrals.
And then I showed you that with the adenosine, that we missed a big portion of them. So if you are relying on a cardiac FET or a ragadenosone, you will miss a big proportion of them. So that's kind of my take on it. And the same with coronary CTA, like it's a gold standard to outline it, but even in this last guy that I showed you, it was not even reported. I had to go back and ask them to relook at it, and it was clearly seen on the angiogram and on the IVUS.
I mean, my other comment is that often when we bring this up at meetings, you do mention and you have stressed that, even surgeons who operate on this needs to have experience and expertise on it and to know where to cut. Whereas my experience whenever we bring it up is, oh, anyone can do it, which I think is not the right response.
I absolutely agree with you. And then I know that when I came to this new center here working with Dr. Guy, I really had to do all the measurements for him. I would do a map like this. And then when he is in the operating room, we would play the angiogram and we would say exactly from where to where. I saw it on the IVUS because I have a picture of both. And then we basically map it out as he is going with the robot. This is what we did even yesterday in the operating room. It's not an easy procedure, but when I first started, he said, "Oh, I don't believe in these, even though I do them." But when they're appropriately selected patients, the ones that we are convinced that we've exhausted all the other possibilities of medications, the fact that we recognize that they have spasm and we've treated that, the fact that we recognize they have microvascular disease and we've treated that, and despite that they have symptoms, that's when we go as a last resort. It's never, something, we diagnose a bridge and it's positive and we send them to the operation. It's the exact opposite. We really take this at the very last resort when there's nothing else helping.
Yeah. Does anyone else have any questions for Olga? I don't see any hands up. Okay. In which case, I would like to thank Olga very, very much for this excellent talk. We've had lots of unbelievers, including, I would say, myself early on, but things are changing. And I think you've given us a very convincing talk about, how and why, these things, although we're born with, that can cause ischemia and cardiac death at a later stage in life. That's where people struggle, I think. Everyone goes, you're born with it, so why is it causing problems now?
Yeah. And then I always make sure I ask my patients of what happened, when did they first notice symptoms, and there's always a concomitant trigger. Like in this young man was the strep throat, which was very severe, and it was delayed treatment. And in other patients, it could be stressful event or ruptured, Minoka.
You are.
But don't think about it as something that necessarily needs to be dealt with surgery, but something that is a package and may include other problems like increased inflammation, autoimmune conditions, as well as coronary spasm and microvascular disease.
Yeah, back to being a true cardiologist.
Yes, exactly. Well, thanks for the opportunity, and congratulations on your symposium. And I appreciate, I see a lot of people in the room, so thank you very much for participating.
No, thank you very much again, Olga. We'll catch up soon.
Thank you. Bye.